A woman's lifespan sees a plethora of hormonal variations right from peripubertal period to menopause. Now, these benefits that we see during the peak of the hormonal health of each woman could be in the form of their reproductive health, which everybody knows, but it's also in the form of their bone health, their metabolic health, their cardiovascular protection. And then this may start to fade away if the hormones go haywire, and this can present in the form of PCOS or ultimately menopause as well. Today, we have a renowned expert, Dr. Aimee Browne. She is a renowned reproductive endocrinologist, triple board certified with over 20 years of experience. And it's a privilege to have her. And I welcome her to the podcast with us.
Thank you so much. I'm excited to be here.
It's an honor to have you on this show, Dr. Brown. I'm going to start with a very basic question. What exactly is PCOS? Would we say that is it multiple cysts in the ovary, or any woman with irregular periods means that she has PCOS? And what exactly are the symptoms that a lady should look out for to be suspected to have PCOS?
So, PCOS is one of my favorite things to talk about. PCOS is the most common metabolic disorder of women, and it affects 10 to 15% of us. So, it's something that all providers are exposed to. And the hard part about PCOS is that we don't know exactly what causes PCOS. We know a lot of the characteristics of PCOS. We know some features of PCOS that cause the issues, but we don't actually know the etiology of PCOS. But I think to explain the symptoms that women see with PCOS, you have to kind of go back to the pathology of PCOS. And I think of it as kind of a triad, a circle of dysfunction that is based a lot in insulin and insulin resistance, obesity, and inflammation. And when you get to the core of PCOS, that insulin resistance, the high insulin levels, they cause the body to gain weight, to have inflammation, and that in turn causes more insulin resistance. And both of those things cause elevated male hormones or androgens, and those things cause inflammation. And what happens in the level of our bodies is that the high insulin inflammation causes disruption at the level of the brain. So, normally, as women, our bodies are sending signals from the brain in this very coordinated, specific pulsatile way. And that hormone signal tells our bodies to make an egg every month. And when you have that triad from PCOS, the hormone signals from the brain are not coming in the correct way. And so we don't go through that normal cycle of making an egg every month. At the level of the ovaries or the eggs, that's also causing issues with the environment. So they're not developing as well as they should. They're not functioning as normally. And it also affects, from being a fertility specialist, it affects how the eggs actually create the embryos and how it implants into the uterus as well. So that dysfunction and dysregulation at all these different layers in a woman's body cause the symptoms that we see with PCOS. So what a woman is going to present with first is irregular cycles. So she may skip periods altogether. The cycles can come irregularly, like every 3 months or 6 months. Some women never get a period without taking medications that have PCOS. They're going to see elevated male hormones, either in blood work when they go to the doctor or something symptomatic like elevated hair growth or even balding in a male pattern. And so those are the kind of symptoms they can see: fatigue, easy weight gain, difficulty losing weight. That irregular bleeding can also not only skipped periods, but it can be frequent cycles. And so those are typically the symptoms that women are going to present with. And as a fertility physician, I often see women that have PCOS because that lack of making an egg every month and not ovulating also contributes to their infertility.
Yeah, absolutely. So, Dr. Brown, you also mentioned insulin resistance. Now, can you expand a little more on that? We often talk about insulin resistance mostly in the context of people who are overweight or obese and the diet and lifestyle that's contributing to it. So, would we define PCOS as a diet and lifestyle disorder? And are those the only factors that are leading to PCOS, or is there something else also that may be contributing to people who have PCOS?
Yeah, it lifestyle factors matter, and they are the number one treatment, but they're not the cause. Um, so that underlying insulin resistance that women have with PCOS is what causes the dysregulation of the system. And when I watch like podcasts or experts talk about insulin resistance, it's always my favorite thing to hear the analogy that we use for insulin resistance and sensitivity, because I think it just really shows, that person's personality. My analogy is like a nightclub, and you want to think about, and I explain it to my patients this way: think about a group of people that really want to go to this fancy nightclub, right? They want to get inside, but the door is guarded by a bouncer, right? And your name has to be on the list to get inside the club. So, in this analogy, the club is the cells. So, let's say it's your skeletal muscle, and the glucose or the blood sugar are the people standing in line, and the bouncer and the list are insulin and the insulin receptor. And so when you have insulin resistance, think of it like the bouncer is there and it's preventing the people from going inside the club. And sometimes that's really important. Like, you need to protect the cell for whatever reason. And we'll talk about, I hope, some physiologic times for women that this is actually really, really helpful. But in excess, if you have such a resistance to get inside the club, inside the cell, now you have these people standing outside getting rowdy, right? So now you have all this blood sugar. You're going to call in more bouncers, right? You're going to keep more people out because now there's all of this kind of mayhem outside. So that extra blood sugar, where is it going? It's going to the liver. It's causing fatty liver. It's disrupting, as we talk about the female reproductive system, it's disrupting the brain. It's disrupting the ovaries, all of those things that we are talking about. So women that have PCOS, their system is already naturally set up this way. And we don't know exactly why, but if you think about it historically, the body, and I tell patients that have PCOS, it's actually created very beautifully for times of famine, for times of stress. Like, you really want your body to be able to live in a time where there's not a lot of food, there's stressful events. Women that had PCOS were probably protected, which is why it may be so common in our current, our current population. But when you have high levels of sugar everywhere, processed foods, lack of exercise, then that insulin resistance becomes a problem. And we have all of these downstream effects and manifestations of that. But lifestyle didn't cause it to happen. It's just predisposed to be that way. The reason lifestyle is the number one recommendation is because getting our bodies back to the way that they were potentially meant to exist, with high levels of activity, whole foods, a lack of processed foods, then the system works well. The glucose goes into the cell, people go into the club, they do what they need to do, the system functions really normally. So that's why, I try to always frame these pathologic systems right now in a more positive way, because I don't want women to feel like they're broken. They're not broken. The system is made to function really well. It's just not our current environment.
I love the analogy. I've never heard of it. It's very impressive how you can explain it.
Tell you, it says a lot about the person
I
when
know,
you listen to
right?
their analogies. Yes.
Would you say so? Is there a genetic component to it as well?
There is. It's not one of the disorders that has a single gene mutation that we can screen for, but we do know that PCOS does tend to run in families, so it's more common. We also have a lot of generational effects from PCOS and elevated blood sugars. So there is some programming that's done in utero for us and for our kids. And so the environment that they're in helps set them up for their metabolic programming in life. And so that is a form of kind of genetics of this, kind of passing it on. And again, it is more common in families, but not by a single gene.
Right. So we can say that there is some role of genetics, and then the diet and lifestyle is predisposing people or women to get PCOS. But then there is, it's not always true that diet and lifestyle will always cause PCOS. So if I have a poor diet, a poor lifestyle, I'm not always going to get PCOS. Would that be a correct statement?
Correct. I think that is true. That there are some women who can eat certain things, and some women that can have a very similar exposure and have a different response. And I have another analogy that I like to tell people, because women with PCOS are often very frustrated when they come in. They know that they have a harder time losing weight. It's more difficult. They feel like they don't eat that much, but anything that they eat, they gain weight. And I always start with acknowledgement, like, oh, that's your history. Yes, you have a hormonal issue. That is very common. And it is, like we talked about, this underlying insulin resistance. So we'll take an example of, let's say, two books. Like, let's say you have a Dr. Seuss book, like The Cat in the Hat, and you have a seemingly difficult book like War and Peace, let's just say. And someone says, is this book easy to read, or is this difficult? And I think our initial inclination is to say, well, the Dr. Seuss book is easy and War and Peace is hard. But let's take a 5-year-old with dyslexia. And I know this from experience because I've had this child, sees that Dr. Seuss book, and it's not easy. It actually can be hard. So that book has not changed, but
Hmm.
the person going to that book is different, right? So let's take a cookie. You have someone who eats a cookie who is insulin sensitive. They have no PCOS, they have no underlying metabolic disorder. They eat the cookie, the insulin goes up, it attaches to the receptor, bouncer opens the door, glucose goes in, blood sugar is used by the muscle. That's it. It's processed. In someone who's insulin resistant, that bouncer does not let that cookie just come into the cell. The high insulin level, you have to remember, hormones are always telling the body what to do. And insulin's message to the body is store fat, don't burn fat, keep high blood sugar in the system for some reason. So that same cookie is going to be not burned, not put in the cell, stored as fat, high insulin level, make the insulin resistance work. So it comes back, right? Is the book easy or hard? Oh, it depends on who you are. And women that
Absolutely.
have PCOS, it's difficult. They cannot eat the same way because they're metabolically not the same people, but they're
Right.
not broken, right? It's not their fault that they respond to a cookie in a different way than another person.
Wow. I mean, it's put in a very empathetic manner, and I'm really glad that you're able to explain that in this sense, and I'm sure your patient population would be very happy to have you as their specialist. So, would you say that once somebody's labeled as having PCOS, will that be defined for life? Like we're talking about, okay, their genetics is there, they have a predisposition, and then with diet and lifestyle, ultimately they ended up having PCOS. Would we call them PCOS for life then?
I think that from the patient's perspective, that once you have a diagnosis of PCOS, you know that your risk factors for chronic disease, including diabetes, heart disease, depression, all those things are increased. And so I think that women should say, I've had a diagnosis of PCOS. I should be screened appropriately, think about my life that way, have my lifestyle be in a way that's protective. I think they should do that forever. I think the problem with PCOS, and when I see patients that come in, there's often a lot of confusion. Like people will say, well, someone told me that I have PCOS, but then someone said that I don't have PCOS. And it's not like the diagnosis of diabetes where you have like one level,
That
basic
defines it.
criteria. You have a hemoglobin A1C over 6.5, you're diabetic. So PCOS is a diagnosis of exclusion. And so you have to have two of three clinical features: irregular cycles, elevated male hormones that could be in blood work, or symptoms like acne, oily skin, or increased hair growth, and then polycystic appearing ovaries, either on ultrasound or with the new diagnostic criteria, they've added some AMH blood testing that can also fit that criteria. You have to have two of the three. And then we have to exclude all the other disorders. So let's say someone comes in, they have irregular cycles, polycystic appearing ovaries on ultrasound, and we've ruled out all of the other impersonators. So diabetes, thyroid disorder, prolactin issue, hyperplasia, adrenal hyperplasia. So they have a diagnosis of PCOS. Now, let's say that that woman loses weight. She uses a GLP-1, or she modifies her diet, she's exercising, and she starts to ovulate regularly. Now she has lost a diagnostic criteria because she has regular cycles. Does she not have PCOS anymore? Based on the criteria, she doesn't, right? But that doesn't make any sense. She has modified her lifestyle so that now she's ovulating, but she still has PCOS. So it really can be very confusing because women present to their providers at different stages of their life, and they may or may not fall into the criteria at that time. And the other thing is there's a lot of overlap with obesity, diabetes, and PCOS. And so because there is so much overlap in the pathophysiology of insulin resistance, obesity, inflammation, and PCOS, sometimes it's very difficult to tease out what they have. Now, after practicing fertility medication or medicine for 20 years, I'm pretty practical, and a lot of times I'll say your presentation is a little confusing, but ultimately it probably doesn't matter. You still need to do the same things for your lifestyle, and I still need to do the same things to help you ovulate, to help protect your uterus, to treat your blood sugar. So I think it's a complicated diagnosis, and it's kind of complicated throughout our life. But it's something that women should be aware of, and our providers should be aware of, and they should be screened appropriately throughout life.
So, in terms of screening, Dr. Brown, what would you recommend in terms of the testing? We talked about the clinical criteria. Is there
Yes.
any investigation, including ultrasound? Is that a mandate, or is that just a criteria? And if we may not need it if we have the two other criteria fit in already?
Right. You don't need it if you meet the other criteria. There are several different diagnostic criteria for PCOS. Sometimes you need irregular cycles in certain criteria, sometimes you don't. But in general, you only need 2 out of the 3 criteria, so you don't need the ultrasound. And even if you are using that polycystic morphology or having lots of eggs in the ovaries, now we can use blood testing. That AMH level was not part of the diagnostic criteria before this most recent guidelines came out, but now it is. So you really don't need an ultrasound to diagnose PCOS. You really only need those clinical criteria. And then you do want to have some blood testing, which is also really confusing because we order, like in my clinic, they're called PCOS labs. And if I'm not careful, someone will come back and I will say, your PCOS labs are normal. And they'll say, great, I don't have PCOS. And then I'm like, oh, no, that means you do have PCOS. Because the PCOS labs are labs that we use to rule out the impersonators. So I'm screening for diabetes, but also for the level of insulin resistance and glucose or blood sugar intolerance she has. I'm checking a testosterone level because I want to make sure that there's not an underlying ovarian testosterone secreting tumor or something like that that's going to have a really high testosterone level. But if it's a little bit high, then I'm like, okay, that's what we see in PCOS. We want to rule out adrenal gland overactivity or hyperplasia, a prolactin disorder. I'm running through the list of labs we order. So all those things are the PCOS labs. And then in very specific, women will rule out even more rare issues like Cushing's or a growth hormone issue. So there are the labs that we do to make sure that there's nothing else, that we have the right diagnosis. And then I have another set of labs that I'm doing to make sure that metabolically that she is prepared and safe for pregnancy. So I'm checking her blood sugar, making sure it's okay for me to help her get pregnant. I'm checking her cholesterol to make sure that her cholesterol and triglycerides are not at a place where she's going to be at risk for a cardiovascular event during pregnancy. Has nothing to do with the diagnosis, but I still put it in my PCOS labs because we know that women that have this disorder are at higher risk for those things. I also always check liver function tests. This is not part of the diagnostic testing that's recommended in the new guidelines, but fatty liver is so common. I went to a conference that said fatty liver disease right now is the number one reason for requiring a liver transplant in the future.
Yeah.
So I always screen because when we talk about that analogy, when all that blood sugar is out there, it has no place to go. One of the most common places it goes is to the liver, turned
Remember.
into fat. And a lot of times women are just told, yeah, they told me I had a fatty liver. It's not that big of a deal. It is a huge deal. And we really have to engage with women in these times of like pre significant disease. Like, no, you don't have liver failure. No, you are not diabetic, but you are set up for a lot of bad things that can happen in the future if we don't intervene right away.
Absolutely. That's, bang on. And a lot of emphasis now is on prevention because ultimately you don't want to end up having liver failure secondary to fatty liver. Um,
Correct.
yeah, yeah. And you mentioned, Dr. Brown, about conceiving and difficulty conceiving in PCOS. Um, how likely? So, what are the percentages of women who have PCOS end up not being able to conceive?
So there's a high percentage of women that have PCOS that do not ovulate. But the majority of women that use fertility medications, for examples, would be Clomid or Letrozole or injectable hormone medications, will ovulate in response to medication. I think it's like 80%. And again, me and my analogies, I always tell my patients, like, think of your ovaries like a car, like something that has to take you from point A to point B, from not being pregnant to pregnant. And the beauty of PCOS is that your ovaries are normal. There's a lot of eggs, and typically the eggs themselves are good, but the environment that they're in is what needs to be adjusting. So I say, okay, the car is fine, but right now your car is like in the middle of a snowstorm and it can't get to where it needs to go. And so that's what we need to do. That's what we need to focus on. But it is one of those disorders that's great because there are so many interventions that we can do to help with that environment. Very different from someone who has an ovarian issue, like a diminished ovarian reserve or ovarian failure. Those are things that are very difficult for us to fix. PCOS is not.
Well, I'm loving the analogies. I'm really having fun with
I know.
them.
I'm full of analogies.
That's really, really, really fun to hear them. So, what about the complications that a lady should expect if they do have PCOS and there was some degree of difficulty conceiving, finally they were able to ovulate and they conceived. What are the rates of complications that somebody should expect if they have PCOS?
Right. So, because of that underlying metabolic disorder and insulin resistance that women have during pregnancy, they have a much higher risk of gestational diabetes. And so, women that have PCOS, or really any risk factors like obesity, age over 30, family history of diabetes, or family history of gestational diabetes, really should be screened early in pregnancy for gestational diabetes. Women that have PCOS have a higher rate of miscarriages. There is a higher rate of congenital anomalies if the blood sugars are severely elevated. Not so much if they are controlled. So it's very important preconceptually to make sure that the blood sugars are more within the normal range. And if women that have PCOS develop gestational diabetes, that does increase the risk of the pregnancy. So you're going to have higher rates of C-section, preeclampsia, and other hypertensive disorders. It puts the baby at risk for being macrosomic or large, having issues after delivery for the baby to manage their own blood sugar and glucose levels. So there are risks associated with the pregnancy as well.
What about during after delivery? Is there a higher chance for women who ended up developing gestational diabetes to go on and develop a chronic diabetes or type 2 diabetes? And in continuation to the same, what is the risk for the baby in terms of a future risk of the baby developing diabetes?
Right. So the risk if someone has gestational diabetes that they develop frank diabetes in their lifetime is it's so high. It's like 7 to 10 times higher of developing a woman developing diabetes in the future if they have gestational diabetes. And the postpartum period is really an interesting setup that we have done as a society. You know, think about pregnancy as being a stress test for
Mm.
your metabolic health. Like it really is. And again, to put a positive light on this, um, I can pull it back to the analogy. So let's say that you are the owner of the main club, okay, but you open a sister club down the street and you
Uh-huh.
want people to go there too. So you make it a little bit harder to get into your main club, but your main goal is to get people to go to your other club because you care about that too, right? That is what we are doing as women. We have to make it a little bit harder for the blood sugar to go into our own cells because we have an entire human we're trying to create that requires blood sugar. So we become a little bit more insulin resistant during pregnancy from the placenta. And we shunt that blood sugar to the baby because that's what the baby needs to, even at like the embryo development level and brain development. The baby needs that blood sugar. The baby needs us as the mom to use more fat instead of blood sugar, right? So it's all part of this beautiful system that women are designed to do. The problem is if both systems aren't healthy, when you have that insult and that stress test, it can show that the original system was not that healthy, right? The club that you are decreasing the attendance to has to be overall healthy because if you mess that up in any way and that club fails, okay, there was a problem there in the first place. And so, what gestational diabetes really is a stress test for women. And if you develop diabetes, you failed the stress test. The problem with postpartum is that when you deliver and the placenta is gone, then the insulin sensitivity goes back to where you were before, which we just established was not that great. Can you imagine if we took men that had chest pain and did a stress test and found it to be grossly abnormal, and then afterwards we're like, avoid treadmills? And we didn't do anything else. Like, we didn't change their diet. We didn't get them angiograms or have surgery or anything. We just pretended like the abnormal stress test never happened. That
Mm.
is what gestational diabetes is like. It's like we totally ignore the fact that we have discovered this underlying issue. And then not only do we help women heal metabolically by having them rest more and eat better. Now we're postpartum and we're not sleeping. We have a higher level of stress. We're healing, so there's more inflammation. You eat when you can. How many times do you hear this? Eat when you can, sleep when the baby sleeps. Like, it's crazy. And then half of the people that were supposed to be screened afterwards don't get screened because we pretend like the stress test never happened, where we actually should be engaging so much more with these women.
Wow. Um, I'm really having fun with the sister club and the main club. I,
I am telling you, you can use it. Feel happy to steal my analogy. It
I,
is actually
I,
really fun.
I will quote you when I use it that Dr. Brown says that. No, but like you put it in such a nice way that people would probably get what you're saying, that there is some degree of stress that's already been there in the body, and people just ignore the fact that that was there with the gestational. And I see a lot of kids coming to me with the tendency towards pre-diabetes. They've already had that, and the mother has had a history of gestational diabetes, and then she ended up developing frank diabetes, but then nobody had taken care of that aspect of gestational diabetes after the fact, and then the same thing passes along to the child as well. So right, I mean, it's just beautifully put in by you that it is very important that that stress also be taken care of even after the delivery. I mean, we do
Right.
need to take care of the environment. Can you shed light on what would be the ideal environment for every woman, for a house, as a household? What's the low sugar household culture that everybody should imbibe? Or is there one?
Um, there is, but I think it's like almost makes me a little sad as I sit here and I'm about to say this because I know that it's so difficult and that my house is not set up the way that I would want it to be set up. So, in this kind of marriage of fertility and lifestyle medicine that I'm trying to create, I have a NEST framework, which is basically set up on the lifestyle medicine pillars. And so the N is for nutrition, whole foods, mostly plant based diet. E is for exercise. S is for restorative sleep. T is for toxicity avoidance. And right there, I'm going to put added sugars, processed foods, ultra processed foods, and then stress reduction and social support. And that's for me a fertility framework. But really, it should be for all of us. And that is how a household really should be set up. So at meal times, we should be having high levels of protein, which are going to decrease the insulin spikes that come with those carbohydrates. We should have complex carbohydrates and not simple carbohydrates like these cakes, pies, and cookies. Lots of vegetables. Half of the plate should be fruits and vegetables. And then we should be avoiding these sugars and processed foods. Um, so, uh, soda, juices, we should be drinking water, staying hydrated. We should be moving as a family, as a rule and not as an exception. Kids need to go to sleep. Parents need to go to sleep. 7 to 9 hours of restorative sleep is what we need. We need to be avoiding these toxins for our kids and for our future. So, all of these processed foods, processed meats, um, those are things that we should really avoid. But the thing that makes me sad is as much as I know, as much as I try to live this, it is so incredibly difficult to avoid all of the processed foods and everything that we have. Um, in our houses and that our kids are exposed to and we're exposed to all the time. It's
Right.
really a setup.
Yeah, it is. I completely agree with it. The environment that we live in, and it's so easy to just get stuff. I mean, it's just easy to buy stuff. It's just easy, and it's actually cheaper to buy um, ultra processed food, all this junk food, and the availability of it is like in abundance. So it is hard to convince ourselves and kids who are more exposed to this that okay, I mean, this is where we draw the line. And people who have gotten used to the idea of eating this food, there is a behavioral element that also comes into picture where the new habit building is very, very difficult for them to imbibe a new way of eating. So, and there's more talks about how behavioral element and behavioral modification is becoming more and more important to the idea of imbibing these changes and getting used to the newer taste buds or probably going back to the ancient ways of eating. And that's what we're probably doing these days to understand how to make it easier for everybody to imbibe this difficult routine, I would say. um,
Yes. And I think it's important to have conversations like this, and have conversations with as a family and, with the kids. So there are, because you also don't want to create an issue around, food. Like I have more of a tendency to be very black and white, like, oh, that's a bad food and this is a good food. And it can create issues that we also don't want to create in our kids. And so I often will just have conversations. I make my kids read labels. And so I will say, like, well, how much, I want you to get this much protein in whatever your meal you're about to have or snack. How much protein does that have? Compare it to this. Okay, what's that label say about the protein? Okay, how much added sugar does this have versus this? And so at least we're having a conversation about it. And ultimately, maybe that choice is not the best one, but at least there's some awareness. Whereas when I was growing up, again, I have a very strong family history of obesity, diabetes, cardiovascular disease. We didn't really talk about those things in my house. So I had to learn a lot of that on my own. And, even not in medical school, but just on my own. And so having those conversations, I think, with the kids is really important. And even when they're maybe not making the best choices, at least they have a level of awareness, which is
yeah,
nice. I
yeah,
remember we
I
went to
completely agree.
a neighborhood birthday party, and we next door have a family, and the dad is a physician, and next door they have also two parent physician household, and the kids were outside and they were getting ready to eat cake, and the kids were just chanting diabetes, diabetes,
Oh
diabetes.
wow.
And I'm
Oh
like,
wow.
well, at least they are aware
Yeah,
of what that means and that they're about to consume something that has a high level of sugar. I guess that's what we should take from this
yeah.
cul-de-sac of chanting about disease. I don't know.
Dr. Brown, this is a wonderful conversation, and I'm really glad that you were here to give such an expert at enlightenment about so many things. I've learned a lot, and then there's a lot of analogy that I've learned that I can also use and quote you on those. Let's just summarize also. Can you, if you have some final thoughts, and then we can summarize a few things for our public.
Yeah, I think having specific discussions about women is just really important for us to continue to have. If you compare women to men, men with metabolic disease in the future, they walk more of this kind of straight line. Whereas women, we have so many different points in our lives that have these like mini metabolic hits. Puberty, we talked about pregnancy and gestational diabetes. We have PCOS in our population that men don't have. Um, I mean, we could spend another hour talking about perimenopause and
Menopause. Yes.
menopause. So we have all of these metabolic hits. And then, I mean, even if you think about it, every month when we ovulate, if we have normal cycles, we have this little hit of insulin resistance that men don't have, right? When we ovulate and make progesterone, progesterone makes us insulin resistant by design because every month our bodies are ready to accept an embryo and feed that baby the glucose that it needs. But that means every month, regardless of how hard we're trying, and I know this by experience, you're going to be hit with fatigue and cravings and weight gain and bloating. And it's such a beautiful system to be created that way, but man, does it really make it hard. And so women are not the same as men, and we do have to acknowledge that we have all of these different metabolic hits throughout our life. And so we have to talk about that. We have to be aware of it. But also, I think it's good to celebrate because as women, even though sometimes we have these delayed diagnoses in different diseases, we really shouldn't. Like, we as women and as providers should celebrate all these opportunities that we have to diagnose prediabetes, glucose intolerance, insulin resistance. Every pregnancy, we have a stress test. Really, every month, we have a stress test. We have periods that every month your body is going to check in with you and say, yep, everything's working good this month or not. And so there's just so much that women have that allow us to intervene in all these different opportunities. We have 100% of screened pregnant women have a glucose challenge test. There's argument whether it should be done earlier or not, but just think of that. Like, every pregnant woman gets a stress test that men don't have the opportunity to have. So we really should be able to have earlier interventions, earlier diagnosis, better treatments, improved lifestyle. So if we don't ignore the system and what the body is telling us, I think it really could be used to our advantage. And then also, it's just kind of amazing, but we are drivers of not only what happens in our bodies, but like our kids and our kids' kids, because we're setting them up for their metabolic health. So I just think the female body is really amazing. And we should just celebrate, I think, the way that we're made, and just use that information to help guide us in a positive way.
That's so beautiful. That's really beautiful the way you put it. Um, Thank you.
Yes.
I'm really excited that we're having this conversation, and I'm really glad that you're here. And it's been such a pleasure that we had such a good connect and learned a lot and talked a lot of things. Let's just give 3 points to all the people, all the ladies out there, as to what would be your take home points, where you would say that this is what you need to do to prevent PCOS. And if you do get PCOS, this is how you can diagnose it early and probably not go into infertility issues as well.
Right. Okay. So I would say the first thing is, do not ignore irregular menstrual cycles. So, this is something that does not require a blood test. It doesn't require a visit to the doctor for women to be aware of whether they have regular monthly cycles and are ovulating. If you are not ovulating, if your cycles are not regular, please go be seen. I don't know how many times I see women that have not had a period for a year. That just should not happen. So that's number one. Monitor your menstrual cycles, and if they're not regular, go be seen. Two, I would say it's so important to have the appropriate health screening that we need as women. So many of us should be screened for insulin resistance, diabetes, pre-diabetes every year, or at least every up to 1 to 3 years. There are so many risk factors right now with obesity, age, family history of diabetes, gestational diabetes. So I would say get your appropriate screening, especially for blood sugar, as we kind of talk about this PCOS. And then I would say three would be really follow the NEST framework philosophy if you have a known metabolic disorder, diabetes, PCOS, history of gestational diabetes. You really have to monitor your nutrition, exercise, sleep, toxicity avoidance, stress, and social support. Make that lifestyle so important. It is so important. And then I'll add one more. And that is, as a fertility specialist, I feel like we have a very unique opportunity to see women often before they develop severe chronic disease, but also we are a unique group of gynecologists that also get to see men. And just like all of these things that we've been talking about and how we have all of these, metabolic stress and signs and things like that, I don't want us to completely leave men out of the discussion because infertility also can be the first sign of male metabolic and cardiac dysfunction. So, erectile dysfunction, ejaculatory dysfunction, low sperm count, low sperm motility, DNA fragmentation, all of those things can be related to obesity, diabetes, and cardiovascular disease. And so when we see the couple and you see those things, that is also a potential opportunity for us to intervene and give feedback to the male partner as well. And there are not many gynecologists that get that opportunity.
Yeah, very well said, Dr. Brown. Thank you. A lot of women go through irregular periods, a lot of excess hair or acne, and suffer from what we call polycystic ovarian syndrome. And we had a beautiful discussion with Dr. Aimee Browne, who's triple board certified reproductive endocrinologist, who gave us an expansion of this diagnosis with her wonderful analogies. And I'm really glad to have a discussion with her. And here's the summary that I could come up with, that make sure you get your diagnosis on time and don't ignore irregular periods or absent periods for very long. Make sure you follow the NEST protocol and get yourself screened if you're suffering from infertility for very long. Stay tuned with us for the next episode.